Okay. So first is, what is a healthcare system? What do we mean by a healthcare system? A healthcare system, the elements of a healthcare system is it consists of several units, several organizational units, and it consists of several processes by which a society is basically trying to answer the questions related to production, consumption, and delivery of healthcare services. Okay, so what do I mean by that? Taking you back to the first week of classes, when I started by giving you a general introduction into econ, I said that in economics, it is a subject of decision making, right? It's a subject of making choices. Choices not just at the individual level, but choices at the level of the government, choices of the society as a whole. So here I'm bringing you back to that concept where here in the different healthcare systems, it is the process by which a society decides on what to produce, okay, as far as the healthcare services and goods are concerned, and then how are these produced goods and services going to be distributed. So who should receive these services and how much should they receive, okay? That is a healthcare system. Now you can understand that based on the different countries, every country will not have the same or will not be faced by the same question depending on the situation of the country. The basic question remains the same, that is what to produce and how are the produced goods going to be distributed, but then it depends on the internal framework of the country how they answer those questions, right? And based on those differences, we have the different healthcare systems in the different countries, okay? But primarily, just broadly, you can divide a healthcare system into two categories. A centralized system and then a decentralized system. Okay. A centralized system, as you can understand, you can guess a little bit from the name. A centralized system is the one which has maximum government involvement, right? So government is the one which takes the crucial decisions about what to produce and how are these healthcare goods and services that are produced, how they are going to be distributed. Whereas in the decentralized system, it is more like a free market system, and we have been talking a lot about free market in the context of healthcare, and we have been talking about what are the benefits of the free market and what are the disadvantages of free market. So basically a decentralized system is a free market system where the market decides, the producers and the consumers, because you know market is an institution where the buyers and the sellers, the producers and the consumers, they interact and they come to a decision. So in the decentralized system, it is the free market that decides what is going to be produced and who gets the produced goods. Now, as a deviation or as a variation of the decentralized system, in the real world, in certain countries, a decentralized system is also the one where you have more role of the local governments. Rather than the central government of the country, it is the local government, let's say the state governments or the provincial governments or the county governments, which have a greater role in deciding this. Okay? Now, those are the two basic differences in these two systems. Now, of course, like I tell you that in economics, we always, we like taking the middle path, right? We never say, okay, this is good and that is bad. We always say it depends. There are advantages and disadvantages of everything. So similarly, here in the centralized and the decentralized system, we also do have advantages and disadvantages that are related, okay? So the advantage of a centralized system is that, so this is a government-run system, right? And you know that when the government is running something, it's a large-scale affair. It's a macro affair, okay? And the benefits of this system comes from that large-scale affair, which in economics, we call it the economies of scale. And you know about this, but this is probably the first time that I'm using this terminology, but you know the concept, and I will tell you in a minute what I mean by this. Okay, that's the first one, that's an advantage. Now, if I digress a little bit and take you back to our micro review class on cost, if you remember that diagram where we had output and we had average cost and we had that U-shaped curve which was the average total cost curve, right? And that was the lowest point of the average total cost curve. So we said here this is the point where the average total cost is coming down, that's the point where the average total cost is going up. You know that this is where the spreading out effect is dominant. That is the place where the diminishing returns effect is dominant. So you know that part, okay? So basically economies of scale is this zone in the average total cost curve, which basically means that as production increases due to the virtue of large scale production, there is a cost advantage or there is a decrease in cost. Okay, that is what we mean by economies of scale in very simple terms. Okay. So the centralized system has this advantage of economies of scale, and secondly also due to better infrastructure and better utilization of resources, because the government is doing it, there is also better distribution in a centralized system. Those are the two main advantages of the centralized system, whereas in the decentralized system, of course, you have the opposite of economies of scale. That is, often since they are operating within a localized market or these are private players or local governments doing it, there is often a smaller scale of production of output, which means that there is a rise in the cost with every additional output. In other words, this is the zone that we are talking about, which refers to diseconomies of scale. So they do not have a cost advantage. Okay. And also when it comes to distribution, there is lack of coordination. In a decentralized system. So you can see, so far you can see that these are advantages of the centralized system, these are the disadvantages of the centralized system. Then what are the advantages of a decentralized system? Are there no advantages of this system? Of course there are. And those advantages kind of stem from the advantages of free market, and those stem from the advantages of competition that is there in a free market, right? Because we said a decentralized system is essentially the free market system. And also within the local governments there will be some degree of competition, because it's just not one single seller that is determining it, right? So there the advantage of this system is higher degree of innovation. And we have talked about this in the context of competition. We said that certain degree of competition is good because competition triggers innovation in a system. So here in the free market system or in the decentralized system, we have higher degree of innovation, whereas here we have lower degree of innovation. Okay. Now, in today's world, in the global system, when we look at the world, it's very difficult to find a system which is purely centralized or which is purely decentralized. The simple reason being that you can see that there are advantages or disadvantages in both systems. So right now, it seems like there is, more and more countries are trying to move towards a mixed system or a mixed economy, and we have it's coming up, a concept that is coming up in today's world with respect to the healthcare system is the PPP. Can you please put that on mute? Okay, the public and the private partnership within a healthcare system. That is what we see in most emerging in most countries, because there are marked advantages and disadvantages of both. Now, another thing is, over time, as we look at the healthcare systems of different countries, if you were to study the healthcare system of different countries over a long period of time, 20 years, 30 years, you would see that there are changes that come about in the healthcare system. No country runs one single model for a significantly long period of time, because the healthcare system of a country is always influenced by several other factors. It is not a standalone system. It is affected by factors which are social, economic, political, historical events. And since those factors are so dynamic within a country, so dynamic within a society, that they also influence this healthcare system, and as a result of that, the healthcare system of a country does change over time. And you have seen, you have been witness to changes in the healthcare system within your own country, right? You have seen a major difference come up in 2008 with the Obamacare. So similarly, also for other countries, you do have differences happening with respect to the healthcare system. Now, so that means, if this is an ever-changing system, obviously it's a very complex one, right? It's difficult to analyze this healthcare system, but we are going to kind of draw a broad classification. There are some broad types that are available, or broad types that could be distinguished within a healthcare system, and we will talk a little bit about that. Okay? The first one is called the, so we will talk about three basic types. The first one is called the consumer sovereignty model, or simply put, the private insurance model. Okay. What is a consumer sovereignty model? The consumer sovereignty model, or the private insurance model, is basically where there is least involvement of the government. Okay? The government does not play as much role. There is a free market. You buy your insurance, or your insurance is either provided by your employer, or you could go to a private company and buy the insurance, and then you decide on the choice of provider. You decide how expensive the insurance you're going to buy, how much of coverage is good for you, and that you know in the health insurance chapter, from your knowledge in the health insurance chapter, that usually that would depend on the risk propensity of an individual, right? So if you're a risk-averse person, you like to have a good health insurance that gives you more coverage, right? Whereas if you are a risk-loving person, you probably think that, okay, I don't need health insurance, or even if I do, I can do with less coverage, right? So in a consumer sovereignty model, it's the choice of the consumer on how he wants to, what kind of health insurance he wants to have, and this health insurance is either provided through the employer, or an individual can go and buy his private health insurance. So this is exactly what you have in USA, and the government does not have any role in that. This is exactly what you had in USA before Obamacare. There was no government mandate, and I'm not talking about the public health insurance plans here, right? So I'm not talking about Medicare, Medicaid, and all of that. We're just talking in terms of private health insurance. So the consumer was all powerful in that kind of model. Now, the best example would be, USA sometime back before the Obamacare, or even Australia until recent times. Okay, right now Australia has also changed a little bit, and there is government involvement in their health insurance system. So that is the idea here. So there is, what we're trying to say, the bottom line here is that the consumer has a lot of freedom. He has a lot of freedom in the choice of the provider. He has a lot of freedom in what kind of plan he wants to buy, and he can insulate himself. He has total freedom over how he wants to insulate himself against the risks of high medical care costs. Okay? The second model is the social insurance model. in the social insurance model, you have reasonable amount of participation of the government. There is some amount of participation. The way it works is that the government usually pushes for universal coverage. The government recommends universal coverage, and that coverage usually happens through a contribution of the employers and employees. Okay, so the employers will contribute and the employees will also contribute, and they would usually contribute to a non-profit collecting organization. So there is another organization which is a non-profit. Yeah. No? Okay. So we have not broken our track record of having equipment issues.
I'm telling you, I'm so sorry.
Oh, no problem.
See, if I get another call, I'll be back in.
Okay.
But that's all I know to do to fix it.
Okay. So this is a feedback that you guys should give, you know. They usually ask for your feedback because so many times our class has been interrupted because of these issues. So that's a feedback you should give to Monica. Okay.
It's not just your class, just so you know. It's all of them.
Yeah, that's why this is, you know, this is kind of important. So you, coming back, okay, this projector is on now. Okay. So the next model that you have is the social insurance model, right? And in the social insurance model, like I said, you have some amount of participation of the government. That is, the government pushes for mandatory insurance or universal coverage, but usually it is funded by the employer's contribution and the employee's contribution into a non-profit fund, into a fund that is run by a non-profit organization. Okay? And the concept in this model is usually based on the concept of social solidarity. Okay? It's based on the concept of equity, that everyone should have insurance. It's the basic right of the people. So the government tries to ensure that people should have some form of coverage. Okay? And the best example of that would be countries like Germany. You have read in that book, right? Countries like Germany, countries like Japan, Netherlands. Those are the countries that have that kind of plan. But of course, the role of the government, that the bigger role of the government in this kind of model is that the system is subsidized by the government. So the employers contribute and the employees contribute, and that goes into a fund which is run by a non-profit organization, but there is of course subsidizing by the government, by the government of these countries, which kind of defines the role of the government in this kind of model. Okay? And the third one that we have is the national health insurance. Which has the maximum involvement of the government, and often it seems like there is a subtle difference between number 2 and 3, between social insurance and national health insurance. But the basic difference between the two, there are two basic differences. The basic difference between the two is that in the national health insurance, of course, the funding goes through taxes. So the government funds for the program, for the health insurance program, through general taxation. Okay? Whereas in the second one, it is not funded by the government through general taxation, rather through subsidies to those non-profit organizations that collects the funds from the employers and the employees. Okay? And the second difference that you have between the two is in that in this case, in the social insurance model, it is usually the factors of production are owned by the government. So there is public ownership of the factors of production of the hospitals, but at the point of delivery, the delivery is done by the private providers. Okay? Whereas in case of the national health insurance model, both at the point of delivery as well as the factors of production are held by the government. So there is total control of the government as far as the factors of delivery and factors of production are concerned. But in case of the social insurance model, at the delivery stage, it is privately owned, but the factors of production are owned by the government. Okay? Those are the two basic differences that we have. Now, as far as the countries, an example of a country would be United Kingdom. So here you have UK, you have Germany, so now, the next part of it is, are there any differences based on these three models? Are there any differences in the way of financing? Okay, how the systems are financed? Is there any difference in that? Of course there are, okay, and we will study the cases of 3 different countries. I will just tell you a little bit about 3 different countries to throw some light on how the financing takes place. Now, you know that medical care costs are something which, we are all, as consumers, we are all hassled by medical care costs because it's such a large expenditure. Often, when you fall ill, your medical care cost tends to be a large part of your income, and that's why that is the reason that people want to transfer the risk onto a third party, right? We know that from the health insurance chapter, that they want to insulate themselves against that risk. So a third party is involved in the financing of medical care, and irrespective of the system, that is true. Now, that third party could be a private insurance company, as you would have in a free market system, or it could be the government, the central government of the country, or it could be the local governments, okay? So, but there is always a third party that is involved. And like I told you, that if it is a private insurance company, so now we are looking at the financing part. So that's done by a third party payer, which could be a private firm, or it could be the government. When it comes to the private firm, usually the private firm, what do you think, what does a private firm charge for an insurance?
Well, they have costs for their staff, they have to, so how do they calculate?
But how do what, yes?
Premium?
Premium. So the private company would usually charge you a premium. And you know that these premiums that the private companies charge, they do take into account the consumer-based factors, right? So those premiums are, first of all, if you buy an insurance from a private company, usually it's a voluntary payment that you're making. You want to buy an insurance, so you pay a premium and you decide on what kind of coverage you want, what kind of plan you want. Do you want a higher deductible plan, lower deductible plan, more copay, low copay, and based on that you would have to pay a premium. And from the perspective of the insurance company, they are also doing some kind of calculation about the expected payout based on whether you belong to a risky group of consumers or a less risky group of consumer. Remember the experience rating and the community rating that we talked about in setting of premiums. So first of all, here this is a voluntary payment. Okay. And the second one is based on risk category of the consumers. Whereas if the government is financing the system, then in that case they would usually do it through taxes and not premiums. And the taxes are usually mandatory payments, so these are not voluntary payments. And secondly, the taxes are decided regardless of the risk category. Okay. So those are the basic differences between. Now, once again, as soon as you have these third-party payers and you have the different types of third-party payers, that makes this system of healthcare system, this entire thing that we're talking about, it makes it more complicated, and that's why there are so many differences between the different countries of the world in terms of the healthcare system. Now, let's just talk about a couple of countries, and you will be presenting on those countries. Let's talk about Canada. So Canada would probably be in the category of social insurance, and I think I differ a little bit with your point where you say the government covers for 90% of the cost. As far as I think, it is somewhere between 60. So the government usually chips in for about 60% of the cost, and the way that Canada does it, so it is still a centralized system, which means there is involvement of the government, but the central government of Canada, that kind of plays more like a monitoring role, and it is kind of executed through the 10 provincial governments, right? So it is the provincial governments that still pay for the healthcare costs, that still provide for coverage under the National Health Insurance Scheme, the NHI scheme, and then it is the central government that kind of subsidizes these local governments. And usually it is up to 40 to 60% of subsidy that is given to these local provincial governments. And like Whitney mentioned, that it is these private providers that provide the service. So as from the consumer's perspective, you still have a free choice of the provider. You can still go to your chosen provider and get the service, but the provider gets reimbursed by these local provincial governments, and the local provincial governments get subsidized by the central government of the country. That is how it works. Now, if there are any services which is not covered by this comprehensive national health insurance scheme, for those you could buy a private health insurance, right? So if there are certain services that you want to be covered for and that is not covered in the national health insurance, you could still buy your own private health insurance. So it kind of falls, it fits into that social insurance model. What about Germany? What do you think happens in Germany? So the model itself, the scheme itself that you have in Germany is called the social health insurance scheme, right? And what happens there? There is a third organization, there is a third non-profit organization, which are usually called the sickness funds, isn't it? So the employers and the employees, they put their money into these sickness funds, which are non-profit organizations, and then the reimbursement of the providers happens through those sickness funds. And then the government of the country kind of subsidizes those sickness funds. And if you were an unemployed person, then your employer would still have to provide, would still have to contribute towards your insurance into that sickness fund, or it had to come from some other public source like some public pension. So there is dual role, there is dual involvement of the government. The government not only subsidizes those sickness funds, but for people who are not gainfully employed and cannot contribute to the sickness funds, there is also public funding to the sickness funds for such people. Okay? So that is how it works in countries like Germany. So you can see that compared to Canada, in Germany you do have bigger involvement of the government, but it is in a different, it's in a little bit different way. Now the third one, let's talk about UK. Okay, so this kind of fits into the third model, and incidentally the scheme in United Kingdom is also called the National Health Insurance Scheme, and it fits into the third model where the government pays for the healthcare costs through taxation. And not only that, there is limited freedom available to the consumers in terms of the choice of the healthcare providers. So at the delivery stage as well as at the factors of production, owning the factors of production, they are completely owned by the government. There is a major role of the government rather than the private providers. And the way that the government does it, this is also known as, the system is also known as a public contracting system. What is a public contracting system? So the government usually decides on some district health authorities, the DHAs, and the government gives them a global budget. So the government decides on some local authorities, the district health authorities, and gives them a budget and says, this is your budget for this year. And then it is the district health authorities which kind of assess and prioritize the needs of some couple of 100,000 patients within their local area. Okay? So these are so the patients don't even have a say in kind of prioritizing their healthcare needs. It is somebody else. It is the district health authority that is kind of assessing who should be prioritized and what kind of treatment they should get. And once they have assessed that, then it is the district health authority that goes and negotiates with a provider and sends the patient there. So, you know, this is something, if you compare it to USA, it is something similar to your kind of your managed care environment where we were talking about those gatekeeper physicians and things like that. You just go to the gatekeeper physician and then you need to be recommended by the gatekeeper physician if you need specialty care, right? So you cannot choose and go to a specialist immediately. So it is something similar to that, okay, in that context. So the district health authorities kind of assess and prioritize your needs, and then they negotiate with the provider and send you to the provider. And then it gets funded, and this global budget that is given to the district health authorities, that gets funded from the government taxation. Okay, that is how it works in United Kingdom. So you can see that this is the most restrictive system that we can see so far. Here the people don't even have a choice of which provider they want to go to, correct? Do you have any questions so far? Yes.
Since they have like a set budget, how do they account for emergencies or stuff like that happens?
You mean the district health authority?
Yeah, the district. So they're given a certain budget, you know, they already allocated it all. How do they account for it?
So that is the downside of the system. So, you know, it is the budget is decided for the year. It's an annual budget that is given to the district health authority. That means there is cherry picking. That's why I'm saying they assess and prioritize the patients within the local area. So they have a budget for so many people, and they know, okay, we can provide healthcare to the first 300,000 people. So there will be cherry picking of the consumers. So as a consumer, you are at the receiving end. It is somebody else who is deciding about your healthcare need, which is definitely inefficient because you know that healthcare is something which has a very inelastic demand, right?
But even elective surgeries, they push up to like 6 months. If you don't need it,
Yeah.
it's like
So
short surgeries.
you have you have longer wait times because your priority of the service is getting determined by the district health authorities. Okay, so that's a little bit about how it gets financed. Now the next part, the next important aspect that you have in the healthcare field or within a healthcare system is, like we were saying, innovation and the use of technology, right? So let's talk a little bit about that. Now, as far as use of technology is concerned, or here we are talking specifically about technology in the healthcare field, of course, the medical technology, you can divide it into kind of 4 basic stages, right? The first stage is, of course, you know, the basic research where just the medical knowledge gets produced. So here we are talking about the med schools where the research takes place and new knowledge is generated. Then you have the second stage, which is basically the applied research. So here at basic research stage, there is no commercial motivation, right? They are just researching and finding out new ways. Okay. Then you have the applied research or application, where basically whatever knowledge is created, that gets used, or, you know, several, you know, treatments get developed and prevention methods get developed, things like vaccines are developed and things like that. One example would be, making vaccines or coming up with different ways of, efficient ways of surgeries or things like that. And then you have the third stage where there is clinical testing. And then finally, the fourth stage, which is driven by commercial motivation. Right? And in that stage, you usually have the dissemination of that knowledge, the diffusion of that knowledge, and the adoption for medical purposes, and that is always driven by some commercial motive. So these are the four stages. Now, do you think, like, is there a particular stage where there is more likelihood of the involvement of the government, or do you think government can be involved at any stage of this technology research and development?
Definitely number one.
Okay, why do you say so?
Well, even here, the government has funding in the NIH to develop new research and things like that, and then from there, it can be taken to the commercial side.
Right. So when we were talking about those medical schools and we were talking about the hospital industry, we did see that there's a big role of government in providing these grants and stipends to the researchers. A lot of money goes, the government provides that money, right? Then you have applied research. So basically, the bottom line is that there could be government involvement at each and every stage. There is no one particular stage where we can pick and choose and say this is where the government can step in, and in the others the government is not involved, right? So what I'm trying to hit at is that if you have the use of medical technology in the healthcare system, then it is quite possible for the government to influence the use of technology and the development of the technology and the dissemination of the technology at any of these, in any country and at any of these stages, right? So if you have a country where there is a greater role of the government, so if you have a system which is centralized, if you have a system like United Kingdom, and if you have a system like Germany, it is most likely that the government will try to limit these costs, right? The government tries to limit the cost of the use and the development of the medical technology because, in a free market, what happens? If you have, if it's a competitive market, then usually there tends to be overproduction, right? Overuse of these things. We have discussed that in the context of competition. So there tends to be overproduction. For example, in United States, you have so many private players and there is so limited role of the government, there often tends to be overuse and overconsumption of medical technology. Even empirically, there are some papers, and when I give you your lecture notes, you will see that empirically it has been found that in United States there is more use of imaging, there is more use of things like MRIs compared to any of these other countries like Germany or Canada or United Kingdom, because there is nobody to kind of control or regulate those costs. So the bottom line that I'm trying to come to is that the systems, the healthcare systems where you have a greater role of the government, there tends to be lower use of medical technology versus a system where there is a free market. Now, in some cases, that may be a good thing because that helps to keep the medical care costs down, right? It prevents overuse. But in some senses, that there may also be a flip side or a downside to that. And what is the downside to that, do you think?
If you don't get certain testing, you could end up missing cancer, and people could.
Sometimes that may delay the process. Sometimes that may tamper with the quality of care. There are a lot of patients in Canada who need acute care who often cross borders and come to United States for better care and for better technology, for better surgical procedures, because that is not available in that country, or not, there is a long wait time, or they have to, go through different loops to get through that. So there is a downside to that also. And when I give you your lecture note, there are a couple of papers which I want you to kind of go through before your presentation. Just Google a little bit, not that I'm expecting you to read all the papers, but take a look at how people have empirically studied that in a system where there is more involvement of the government, there tends to be less use of medical technology, and there are advantages and disadvantages of that. Okay. Now, what can you say? The last part that I want to talk about before ending today's class and ending your teaching for the semester the performance aspect of these different healthcare systems. How do these, what can you say, how can you rate the performance of these different healthcare systems? So USA serves as a very classic example here because of what has happened in USA over the last couple of years. So we moved from a system in United States where it was a free market system and went into a system where, you know, insurance became mandatory, and once again you could have employer provided insurance or you could buy your own private insurance, and there was subsidy given by the government in terms of the provisioning of insurance. So we have, USA gives a very classic example of how you can compare the, you know, the two sides of the spectrum, where you have a free market and then you have government involvement in terms of mandatory or universal health insurance coverage. So, but the basic thing was the reason that this healthcare reform happened, the reason that Obamacare came in, first of what was happening, you know, there were so many people who did not have any insurance, so there was no provision for those people to get preventive care, right? They did not have insurance, and so they would not go and get preventive care. Instead, they would wait and then go for ER. So there used to be more footfall in the emergency rooms, and then when you go into ER and you are bankrupt, you cannot pay, it goes out of the government exchequer. And you know, the government is not paying out of its pocket, but the government is paying the taxpayers' money. So in some way, the healthcare cost was escalating, not just for the government, but also for in terms of the taxpayers. So people who are paying the taxes, they were bearing the burden for people who were not insured, right? So see, free insurance was there even before Obamacare for people, you know, through Medicare and Medicaid. That was there in any case. That has been extended in certain states, that has been expanded in certain states, but I don't think Obamacare says that, okay, you get free insurance. That is not what it is. It is mandated, and it is mandates in terms of certain employers that, okay, if you have a company which employs so many people, you have to provide insurance to your employees. It is mandate in terms of the insurance companies that you cannot discriminate based on pre-existing conditions and things like that. But not essentially, it does not provide mandatory insurance, does not mean free insurance. I think where I'm trying to head at is, even when you have involvement of the government, when government steps into the picture, even then it is not necessary that the performance of the system suddenly improves. Yes, there has been improvement in terms of the number of people covered, right? There were some 40 million people without any kind of insurance. So now the coverage has definitely increased under Obamacare, but that does not necessarily mean that the healthcare costs have gone down, and that does not necessarily mean that the quality of care that people receive has gone up.